Imagine the scene. Sirens, chaos, someone's collapsed suddenly. It's terrifying.
It really is.
And often, behind that emergency is a condition called ventricular fibrillation, or VF.
Hmm.
It's absolutely critical. And today we're going to, well, cut through the complexity and get to the core of it.
Exactly. We've basically taken some focused revision notes on VF and distilled them right down.
To the must-knows.
Yeah, the absolute essentials. The aim here is to give you a really clear picture of VF, like what it actually is, what sets it off, the causes, who's more at risk, what's physically happening in the heart, how you spot it, and crucially, what you do immediately.
Okay, like a high-yield guide for VF.
That's the idea.
Oh.
Straightforward and memorable.
Perfect. So let's jump straight in. In simple terms, what is ventricular fibrillation?
Okay, so picture the heart's main pumps, the ventricles. In VF, they just start quivering really fast, totally uncoordinated, almost like a bag of worms.
Bag of worms. Okay.
Vivid. Yeah, so instead of a strong, organized pump, it's just this useless twitching.
So no blood gets out.
Precisely. This chaotic electrical firing means zero cardiac output, and that leads very, very quickly to cardiac arrest.
Right, like a rowing team just flailing around instead of rowing together.
That's a great analogy. The boat's going nowhere.
Okay, I get it. So what causes this electrical mayhem? What are the main triggers?
Well, we can group them to make it a bit easier. You could maybe think heart drugs as a rough mnemonic.
Heart drugs, okay.
So H is for heart problems. Think a recent heart attack, acute MI, or underlying coronary artery disease, ischemic heart disease, and different cardiomyopathies, too.
Diseases of the heart muscle itself.
Exactly. And E is for electrolyte issues, especially low potassium hypokalaemia. That's a big one.
Okay.
A could be arrhythmogenic drugs. So some prescribed meds, unfortunately, but also recreational drugs.
Right.
For rhythm problems that are inherited, kind of genetic things like long QT syndrome.
The channelopathies. And T for other. Triggers severe lack of oxygen, so hypoxia, acidosis, really low body temperature, hypothermia, even a big surge of adrenaline, like sympathetic stimulation.
Heart drugs. That's actually quite helpful. So following on from that, who's particularly at risk? Who should be more aware?
Good question. Several things definitely increase the risk. If someone's had a previous heart attack or has heart failure, that's significant.
Makes sense.
Existing coronary artery disease, any structural problems with the heart, like those cardiomyopathies we mentioned, and those electrolyte imbalances, especially the low potassium and drug toxicity, they're all key factors.
Anything else? Less common, maybe?
Yeah, there's something called commotio cordis. That's a sudden hard blow to the chest, right over the heart. It can trigger VF.
Wow.
And also, if someone's already having issues like frequent extra heartbeats from the ventricles called ventricular ectopics, or runs of fast heartbeats like ventricular tachycardia, or that specific pattern torsades de pointe, their risk is higher too. Okay, so if we could zoom right into the heart muscle during VF, what's fundamentally going wrong electrically?
So the core problem is a total breakdown of the normal electrical coordination.
Right.
Usually you get this smooth wave telling the ventricle cells to contract together. In VS, you just have multiple chaotic electrical signals firing off all over the place, completely randomly.
Leading to that twitching.
Exactly, that ineffective quivering. And the result, no effective pump, no blood flow. And it deteriorates fast if nothing's done.
How fast?
Very fast. You can go from VF to maybe pulseless VT and then flatline to systole within minutes.
That's incredibly urgent. Now, are there other heart rhythms or issues that could maybe look like VF initially?
Yes, definitely. In that immediate chaotic situation, you have to think about differentials. Ventricular tachycardia, but where the person still has a pulse, can sometimes look similar on a monitor initially.
Okay.
Also, maybe a very fast rhythm starting above the ventricles, like supraventricular tachycardia, but with weird conduction making the ECG look wide and odd, this SVT with aberrancy.
Right.
And we mentioned torsades de pointe. Plus, sometimes just electrical interference or artifact on the ECG trace can, fool you if you're not careful.
Gotcha. So thinking bigger picture, epidemiologically, how common or significant is VF?
I mean, it's hugely significant. It's a leading cause of sudden cardiac death worldwide.
Really? A leading cause?
Yes, particularly in people who already have some form of heart disease. And while it's definitely more common in older adults, it's really important to remember it can hit younger people too, especially those with those inherited rhythm disorders we talked about.
So what would you actually see if someone went into VF right in front of you? What's the clinical picture?
It's Usually very dramatic and sudden. The person collapses, they lose consciousness instantly.
No warning.
Often, none at all. You check, there's no pulse, and they aren't breathing properly, or maybe just gasping irregularly. It can happen without any warning, sometimes during exercise or stress.
Though sometimes there might be warning signs beforehand.
Occasionally, yes. Someone might mention feeling palpitations or some chest discomfort, maybe dizziness shortly before, but often it's completely out of the blue.
And confirming it's VF, how is that done definitively in that emergency?
Well, the absolute #1 priority is immediate assessment and starting treatment, like CPR.
Of course.
But the tool that gives you the definitive diagnosis is the ECG, the electrocardiogram.
What does it show?
It shows that classic VF pattern. Really fast, totally irregular, chaotic electrical squiggles. You can't pick out any normal QRS complexes, no P waves. It's just a mess.
Just a chaotic line.
Exactly. Later on, sure, you do blood tests, check electrolytes, cardiac markers, maybe imaging to figure out the why. But the ECG confirms the VF itself.
Okay, so time is absolutely critical. Someone's in VF. What's the immediate management plan? What do you do?
Right. It's a top-level emergency. You follow the ALS Advanced Life Support Guidelines. VF is classed as a shockable rhythm.
Meaning defibrillation.
Exactly. That is the absolute cornerstone. Immediate defibrillation. An unsynchronized electrical shock to try and jolt the heart back into a normal rhythm.
Is that the only first step?
In a witnessed arrest, sometimes a precordial thump. A single sharp blow to the chest might be tried right at the start, but the main thing is defibrillation and high-quality CPR.
Okay, so shock, CPR. What else?
Then it's the full ACLS protocol. Antiarrhythmic drugs like amiodarone, adrenaline is key.
Yeah.
You'll be thinking about securing the airway, maybe vasopressor drugs.
And dealing with the cause.
Absolutely vital. You have to identify and treat whatever triggered the VF to stop it happening again. And longer term, many survivors will need an ICD, an implantable cardioverter defibrillator.
Right, a device to shock them automatically if it happens again.
Precisely.
So for someone who experiences VF, what's the outlook? What does the prognosis depend on?
It really hinges heavily on how quickly that defibrillation happens. Speed is everything.
Makes sense.
Also, the underlying cause makes a difference, and what other health problems the person has, comorbidities. But with prompt, correct treatment, survival rates are much, much higher than they used to be.
And conversely, the dangers of delay. What if treatment doesn't happen fast enough?
Well, sadly, without that quick intervention, VF is almost invariably fatal. The lack of blood flow causes irreversible brain damage within just a few minutes.
Devastating.
It is. And even for those who do survive the initial arrest, they can face significant challenges afterwards, something called post-cardiac arrest syndrome. That can mean neurological problems, ongoing issues with heart function, even a widespread inflammatory response in the body.
Okay, so pulling it all together, the key things to remember are that chaotic electrical activity, the absolute urgency for defibrillation.
Immediate defibrillation, yes.
And figuring out that underlying cause. It really is an emergency where every single second counts.
Absolutely. Having a solid grasp of VF is just fundamental in, well, any medical context, really.
Definitely. And look, if you want to really consolidate this knowledge, especially if you're prepping for exams like the MSRA, do check out passthemsra.com.
And freemsra.com as well. Great resources there.
Absolutely.
So maybe a final thought to leave you with. Given how vital that rapid response is for VF, what do you think are the biggest game changers happening right now in terms of getting defibrillation to people faster, whether that's paramedic response or public access AEDs? It's an area that's always moving forward.